So this is the last case of the day, and I would like to thank all the staff of the CAT lab, our nurses, Giovanna and Lena, and our anesthesiologists, our technicians, Miriam and Carmine. And so go on with the presentation. Nika, please.
Okay, thank you. Good afternoon, everybody. I present you this 44 years old woman with an history of ischemic stroke due to middle cerebral artery occlusion, treated with unsuccessful systemic thrombolysis and subsequently thrombectomy and stent implantation. She was investigated with apiartic vessel ultrasound, which was normal, and transesophageal echo, which ruled out patent foramen valley and raised the suspicion of systemic right to left shunt. At admission, normal physical examination, sinus rhythm, and normal chest X-ray. On echocardiogram, here you can see the contrast study was positive for late right to left shunt, and our suspicion of pulmonary arteriovenous malformation was confirmed by CT scan. In fact, in these images, you can appreciate the anatomic communication between a segmentary branch of the right pulmonary artery and the inferior right pulmonary vein. So our intended procedure was transcatheter embolization. Thank you.
Okay. Please, Ingo, if you want to do
Yes, this is Ingo Dehnert from Leipzig. I thank you very much for having me here, first time in San Donato Hospital, and for presenting me with this interesting case. And I was told you had this morning already a talk about arteriovenous pulmonary malformation, but the talking person didn't tell anything about the intervention. So we think now we have to make up for that. And the most difficult part in the intervention is to find the fistula among all those vessels which build a lung. So we had problems to find the right vessel. We were at first in the other lobe, so we didn't find it. And then it was difficult to find the right way when we were there. And the next step was we weren't able to put in a catheter because the way was so tortuous. So finally, we are now in the right position. And I don't know which picture you can see already. One big help for us was the CT, which was superimposed, and maybe that's possible to show it. Do you see it?
Yeah.
The superimposed CT. But you see also that's not precisely the right position, but nearly. So it was helpful, but it wasn't enough. So finally, we are now in the fistula.
We can see that very well. I'm not sure if anybody's got any questions.
The diameter.
Obviously, you're using the vessel navigator system to utilize the CT, which is something we do for all these sort of cases as well. So from our point of view, it saves a lot of unnecessary injections and vessels when you can focus in on the correct vessel using the CT and vessel navigator. So it's nice to see you guys use that as well.
Yes, and that's here very helpful, and we are in the right position. We now have a 5-branch feeding artery, and our decision was to put in an 8 mm vascular plug type 2. What do you think?
Any comments from the floor about choice of device? So an 8 mm ADP2. I think for a vessel this size that seems totally appropriate. Do you agree?
Yes.
The other option would be, we again use to these sort of things, is the Medtronic microvascular plug, 5 or 7 mm Medtronic microvascular plug might work here as well, and it's very trackable, but I'm sure the ADP2 will do beautifully.
Yes, I have no personal experience with the other device, so I choose so far always the vascular plug type 2 for this type of vessels. If it's smaller, I tend to use coils because the catheter is smaller to put them in. So,
There are no further questions here. Do you want to continue?
so we will continue. We are still have the wires in. We first take the wires out of our catheter. And we have
Some
to
bubble.
flush it
Some
very,
hair.
very
Yeah.
carefully because we have some air inside. Can I have a syringe, please? And at first we have to take out the air very carefully because this.
That can be very tricky in these cases because obviously it drains directly to the pulmonary veins. So as you're doing, extreme caution about managing air and suck back when you're taking the wire to the catheter is very tricky. So I think you're demonstrating a very common problem that occurs during these cases.
Yeah.
Something. Yes, Jackie.
So we take our time to de-air this.
So as you're doing that, Jackie, Kreutzer just made the comment about doing this on an underwater seal. An easy way to do that when it's removing a wire is to put the barrel of the syringe over the wire, then fill the barrel full of saline, and pull the wire out, and it means you replace the wire volume with saline volume. But everybody's got a different way of doing that. But it's an important concept.
Yeah.
Jackie, you want to explain how you manage that?
We usually would have a bowl of saline and just remove it on the water seal. It's all very commonly used.
I think that's probably a good idea. We thought we have a 5 French guiding catheter, and this would be possible without such thing. Now we have to see whether that's enough or not. There's certainly still some air inside, but it's coming back slowly.
Yeah. It's frustrating because you sometimes have to lose your beautiful position in order to free the tip of the guiding catheter up, but obviously safety first, so I think you're doing exactly the right thing.
Maybe I need again the ventile and one of the coronary guide wires so I can flush it better. I still have air inside. I don't know whether you see it. I'm not happy with this. There's still a little, but still air inside. Maybe now it's coming.
I think again when you manage that, there are lots of ways to think what Jackie described is good, but I find sometimes having the bath on the table is a little bit of a nuisance because it changes the angle that you're having. But I think one of the first things that I managed to get
Still something in. And I need to.
Syringe as a water seal, and it's a nice way of keeping things easy and making sure that you don't suck
I
any
need
air.
to.
This one?
Any other
Yeah.
tips from the floor? Is that Barrett? Barrett's going to tell us how he does it.
You put it on.
You're doing an intervention at this level where you expect that your catheter might wedge. It's not a bad idea to make side holes to these catheters. So they bleed very well, apart from all the things that you just mentioned.
That's a good point. I actually saw a sheet that a company is working with yesterday that has got some little side holes in the tip already built in.
Open or closed?
Okay, we'll back to you. Nobody else is going to give you any better advice, so let us know where you're getting on.
Yeah, now it's much
But
easier.
You push the coronary wire at the end to provide a little
Yeah,
bit of
we have the coronary wire out, so we have no wedge position anymore. And now we are able
Angel, if you want.
to is this contrast?
Yeah, yeah.
So we can have back bleed. Now we fill with the contrast, and you see that now that should be okay.
Stop flow.
No bubbles anymore. So now we have to, we need a second one. I don't want, otherwise. Do we have PEEP from the anesthesia? What's the PEEP? I would like to have some positive airway pressure now.
Umberto.
And can you fill this with water, please? We will do it. No,
So you're specifically asking the anesthesiologist to provide you with higher PEEP than usual
Yes.
to try and ensure you're not sucking in? Okay, that's fine.
Yeah.
We need the PEEP. Positive PEEP.
Yeah, this would be nice. And we put this. We have it? 8? So this would be nice. Thank you. Then we take this both. Yeah. Can you put the ventile on the epsilon?
Yeah, yeah.
Yeah. Put the epsilon on,
But
please.
as you work away, I'll maybe ask again if somebody would maybe comment about where they might
Yeah,
think about strategically placing the plug
Yeah.
here? Has anybody got a thought with an ABP2
No,
about
on the wire.
the sort of disc width, disc formation that they're trying to
Mm.
achieve here?
What I'll
Becky, what do you think? Where would you try and put the three lobes of your ABP2 in this lesion? I think I caught Jackie napping.
Here too.
There's a lot of danger that it could go anywhere, so.
so then you can flush while I. Is
Yeah.
this water
Yeah.
or contrast?
I can flush.
Some water.
I
Yep.
think ABP4 may be a good option
Yeah.
because getting ABP2 there with the same guide catheter may be
Yeah.
difficult to push.
But the
ABP4 has a much lower profile.
yeah. So we now make a wet-to-wet connection. You keep flushing,
Yeah, yeah.
and I try to open it up and to push it in.
Sorry.
Will be a very tight fit.
Can you push it in?
Yeah.
Taking that curve will be difficult.
Yeah.
Yeah. Okay.
The force will go upward.
So now we to put it in
Yeah,
here.
yeah.
We would use the microvascular plug that you mentioned before. Yeah, I think that's
Water.
I think a lot of very theoretical benefits of the microvascular plug deployed through FCA4, for example, the catheter model. It's a very, very smart.
So
So as Carlos Pedro said earlier on, there's more than one way to skin a cat. How are you guys getting along at the moment?
Yeah.
yeah, we are fine. You can see now that there's no air in front of the device, and we are just there. Now we have a lot of contrast still in our catheter, and we try from here to go only backwards with the catheter, not to go too far in, to have the first deployed, and then the second part, and then the third part, and to leave it like this.
Third floor, please.
And from here,
Okay.
we would try to do
This is-
another angiogram.
yeah,
That's
yeah.
contrast or
Yeah.
water?
Water. This is
Be
water.
careful. We
Yeah.
have to be. This is open or
This
closed?
Contrast.
We have to de-air again.
Comment there. I very nearly killed a patient by actually having forward pressure on the sheath and device during this and ruptured the sac into the pleura and gave me a very, very scary.
Where comes the air here?
So I think your commentary there to make sure you're not moving
Now
forward
it is open.
with an unprotected device and sheath is extremely important.
Yes, I think the same. These vessels are very thin-walled, and I also had the problem of hemoptysis while I was putting in. In my experience, it was a coil. Again, I have tried to de-air carefully, and now I can try to do an angiogram to see whether we filled the entire this thing, and I think we can leave it like this. Maybe we could have used.
Great to me. Any other comments? Everybody agree that that looks in great position for release? Confident nodding. So do you feel confident with that? Do you think that looks good?
Yes, we are happy with the position. We
Looks great.
and we now would release it. Should come. Not yet. Yeah.
Yeah, you have to
You've got a big curve.
close.
Shorten
No.
the transfer very easily. So
And then
Maybe someday it will come out. No. It
okay,
took
third floor.
a long time.
Store.
Yeah. That's it.
yes, that's beautiful. So are you going to do a little confirmatory hand injection, or do you feel your previous one was enough because the device
I think my device didn't move. We don't need another injection.
Yeah,
Or Fabio,
no.
what do you think?
No, I think we can do a bubble test with the echo to show no residual shunt. Angelo, please. So,
But probably we will at the moment have.
do you agree?
Yes,
with the
we
bubble
can,
test?
we can do this,
Yeah.
but we should do it through the sheath, not through the catheter, because some little things will go through.
Where do you want?
Yeah. Do you
Okay.
have some
Yeah.
echo contrast?
Yeah.
We use for echo contrast, we use agitated saline. And agitated saline is more agitated if there's some protein inside. So I usually use a little bit of blood, but it's not always necessary. So
Okay.
we do it here the Milano way.
Can you see the echo?
We can see the echo, yes.
Okay.
We both got our fingers crossed.
So I have to.
Angelo,
take my
are you
time.
ready?
Are you ready for the? So then, now we give. It's in 1, 2, 3. Not much.
Not much.
No.
So hardly any bubbles at all. That looks fantastic. I have to say, if it was positive, then it may well be something more.
Yeah.
Angelo, you can go on bicaval view. We can repeat it on bicaval view, please. Bicaval view. Okay. We can repeat here a bubble test if you want.
So we
Okay, now we are ready to repeat a bubble test.
need some more bubbles. Just a second, please. Now we are ready to repeat. I repeat. Very few bubbles on the left side. What is coming from the supravenar cava to the right atrium. That's the anesthesia and the infusion. So
Okay.
we are happy with this. We were not so happy finding the vessel, but now I think it's a good result anyway. I thank Fabio
yeah.
and all of the Milano team
Okay.
for having me here. Thank you.
Thank you.
Excellent. Well done. Thank you very much. That was a great demonstration. Fantastic case, guys. Thank you very much.
Okay. Have a nice day.